Right. Okay. Good afternoon, kids. Right. So your results released, I think, this morning, I suppose. Yes. So I got a lot of messages from students saying that they got through the exam. So I'm so happy about it. Um, and congratulations for the students who completed their theory part. Extremely proud of you all. And meantime, there are few students actually who couldn't get through the exam this time. So you don't have to worry, right? Just revise and do the self assessment first of all. For those who couldn't complete the exam this time, please do a self assessment and see where you went wrong or what are your weaknesses, especially when you take obs and gynae, right? See what topics you are good at and what are the topics that you are not that good at, right? You are not that confident. Okay, so do more and more reading, especially go through your theory again. And even for the people who are taking your OSCEs and going to the next step of your exam, right? You have to revise your theory, Daru. There is no doubt about it. Especially those who couldn't complete the exam this time, please go through the theory again. That's my advice, right? Because theory won't change. The questions can change, but the theory and the basics will not change. So please go through the theory, Daru. Then you will have better understanding and then redo whatever the questions that we did before, right? And while you are doing, don't try to by heart the answers, but just go through the theory and try to understand the basic behind that question and try to memorize and understand that thing. If you all have any doubt, please let me know, right? And please do some hard work this time and definitely you all can get through this time, right? So today I'm going to, actually tomorrow we are going to do this practical session for the OSCEs, right? Practical session, and I'm going to conduct in Colombo, so you all can join, right? And that will be really beneficial for you all for your upcoming OSCE exam. Even for the all format students, this will be helpful for you all. So the new curriculum, new format, definitely yes, right? So there you will really experience what kind of OSCEs you will get and what is the pattern of these OSCEs and how this exam is conducted and the live specimens and live patients especially, right? Because now most of you all will not have chance to do the examination and take history takings and other things with live patients. Okay, with live patients, sometimes you may not get the chance. So tomorrow you will get the real experience, how to get a history from a live patient and how to do the examination, abdominal examinations, and how to identify these instruments. Definitely, you will get some instruments in your exam, right? As OSCE questions, right? So I'll demonstrate all these instruments in detail, right? For what purpose they are used and what special the arrangements are there, what special features are there in these instruments that helpful for your the procedures. Likewise, right? We will discuss all these things and also real CTGs. I will show you all in these OSCEs and then you can go through and you can answer the questions, right? So I think that will be a good practical exposure for your upcoming OSCE exam, right? And the people who couldn't get through the exam this time, please contact Sudhir, the coordinator, and he will also arrange some special things and the special, support for them. So you can contact Sudhir. I forgot to tell that. Okay. Right. All right. So after saying all of these things, right, today I'm going to do a small discussion, small lecture on CTG because I know that most of the students are not that good with CTGs, right? So I'm not going into detail about CTGs because that's beyond, beyond student level, right? Even for a consultant, sometimes some CTGs are very difficult to interpret. So I'm going to go through with you all the basic CTG abnormalities, patterns that will be helpful for your exam. Because definitely, there's a higher chance that CTGs might appear on your exam as OSCEs, right? So you should get ready for that. So after this lecture, that's very important, right? After this lecture, you will have a basic understanding about CTG. That's very important for your exam. Okay. So first of all, as an introduction, what is CTG? C means cardio, T means toco, G means gram. What is cardio? Heart. Cardiothoracic unit, cardiac surgery is like cardio means the heart, not cardio, it's cardio. Toco means what? Toco. Not Taco Bell. What is Toco? What's Taco Bell? What is Toco? You would have heard of tocolytics. What is Toco? What do you all mean by Toco? Toco means in Latin uterus and uterine activity. Yes. The heart, uterine activity, and gram. What is gram? Huddler. Is that so? No. Gram means the graph. So it's a graphical presentation of the cardiac activity of the baby in relationship to the uterine activity. How the baby's heart reacts when the uterus contracts and relaxes. That in a graphical way is the CTG. Okay, why I say like when you take an adult, your heart is there, right? It's covered with the thoracic cage. When you want to assess the cardiac activity of your heart, what you do? You attach some electrode on top of the chest and you get an ECG. Then you can interpret. But the baby is different because baby is inside the mother's tummy, inside the uterus. So the cardiac activity of the baby varies according to the maternal uterine activity. Why? When the uterus is contracting, the blood supply to the baby will be cut off. Baby will be hypoxic. When the uterus is relaxing only, the uterus will get blood supply and the baby will get the oxygenation. Okay. So contraction period means it's a hypoxic, stressful situation to the baby's heart. Whereas the relaxation period is the good for and where the baby get oxygen for its survival. Okay. So depending on uterine activity, the cardiac activity is going to change. That's why when we are interpreting cardiac activity, always you have to talk about the uterine activity as well. Okay, excuse me 1 second. Okay, so when analyzing the cardiac activity, always you have to talk about the uterine activity uterine activity as well, right? So it's called cardiotocogram. So this is a graph, kind of a graph. So when you take a graph, you know, there's an x-axis and y-axis. X-axis is always the time. And as y-axis, you take the fetal heart rate. So there is a calibration, right? Somewhere starting from 70, 80, like that, going up to 100, 200, something like that. This is a calibration. Okay. So when you are given a CTG in the exam, okay, when you ask to interpret this CTG, you have to say, first of all, especially for the all format students, sometimes in your VIVA exam, they might give you these papers. Okay, look at this. Examiner will tell you, look at this. What is this? So first of all, you have to say, this is a CTG. Okay, so when you take a CTG or an ECG, whatever it is, any document of a patient, any investigation result of a patient, first of all, you have to see what are the general information. That means whether the patient's name written there, age, BHT number, right? And on which date and which time it was taken. Those general informations are very important. Because this particular CTG belongs to this particular patient, not to anyone else. That is specific for that particular patient. So when you're talking about this ECGs as well as CTGs, Darwani, always first mention this is a CTG, belongs to Mrs.
RNPK Pereira. She's 32 years old lady, taken on 8th of August 2025 at 1 p.m. Something like that. Whether you are doing OSCEs or whether you are doing your old format VIVAs, right? When a CTG is given, you have to mention those general information. Even ECG also given. When you are in medical VIVAs, if you are given an ECG, you have to hold the ECG like this and you have to tell, this is an ECG taken on this particular date, belongs to this particular patient. Something like that. Because in obstetric, everything depends on the time and the date. The ECG or the CTG taken in the morning may be completely different from a CTG taken half an hour later. So the time is very important. So first of all, first information you have to provide is the general information of the patient. So in the exam, sometimes you may be given a CTG and you may be asked to mention three important observations you made on this CTG. Three important observations. First, see whether the name, age, and those general informations are given. If it is not given, you have to mention one as patient's identification details are not given. Name, age, PhD number, date, and time not given. That is one of the good observations that you have to make. Then what is next, Daru? After these general things, what next? Even if you take a ECG, this is the same, right? CTG, what is the first thing? The baseline heart rate. What is the patient's baseline heart rate? Baseline heart rate. What is the normal heart rate of a fetus, Daru? 110 to 160. If the heart rate below 110, it is called fetal bradycardia. If it is above 160, it is called fetal tachycardia. Something like that. Okay. So the normal heart should be fallen between 110 to 160. That is the normal. Okay. So first thing, see what is the heart rate. Now, when somebody asks, what is your heart rate, Lassie? Can you give an answer? No, it varies. About 2 minutes ago, you were like fallen asleep, like something like that. When I ask a question, suddenly you got up and your heart rate would have gone up now 120, 30. Isn't it? So our heart rate always fluctuates. Maybe also the same. Right? So when somebody asks what is the fetal heart rate, you can't, specifically you can't go this value, but it's fallen between some, when you look at the CTG, roughly you can say at your eye level, at a glance, you can say the fetal heart rate is around this level, like around 120, around 135, 140, something like that. If you go through this CTG, hope you all can see it. Can you all see this CTG? Right? Everybody need to have a look, right? Don't worry. I will demonstrate all these things tomorrow, right? So if you take this piece of paper, right, you can see there are this y-axis is not marked as y, but you can see the fetal heart rate. It's mentioned 30, 60, 80, 120, 150, 160, 200, 200 like that. It's marked on this, calibrated on this y-axis. This axis, x-axis is always the time. It's not marked, it's the time. 1 square means 1 minute. Okay, 1 square means 1 minute. 1 square, the distance of 1 square is 1 minute. Okay, so when you look at the CTG, you can see the baby's heart rate is going ups and downs, and it's not a static line. But overall, average, what is the fetal heart rate of the CTG? You have to take some average value there, not the exact value, but average value. Is it fetal tachycardia? Is the CTG? Is the CTG is going above 160? No. The large proportion of fraction of time, the CTG is fallen between, I would say, 130 to 140. 120 to 140. It's closer to 130, 140 range, isn't it? So roughly at that level, with that baseline, it's going ups and downs, ups and downs. fluctuations. So this baby's fetal heart rate is about 130. You can say 130, 135 or whatever it is. Is that normal? Is that rate is normal? Yes, that's a normal fetal heart rate. Okay, if it is going above 160, the baseline, not the accelerations, right? If the baseline is going more than 160, that is called fetal tachycardia. Going below 110 is called fetal bradycardia. What are the causes for fetal tachycardia? Causes for fetal,
maternal fever?
Maternal temperature, yes. Even for an adult, when you are feverish, when you are having fever, your heart rate is high, right? So fever is one of the reasons. Infection, chorioamnionitis. Any maternal or fetal infection can lead to fetal tachycardia. What other conditions?
Fetal anemia?
Okay, fetal anemia is one, yes. What else?
Maternal thyrotoxicosis?
Maternal and fetal both, right? Even maternal or even fetal thyrotoxicosis, hyperthyroidism. Sometimes baby may be having fetal cardiac rhythm abnormalities, right? Technical like SVT and those things, right? In that case also heart rate can be high. So when a fetus showing fetal tachycardia, you have to think. And the other thing is fetal hypoxia, very important. Fetal hypoxia. When the baby is hypoxic, it can be tachycardic, it can be bradycardic. So infections, we are mainly worried about chorioamnionitis, infections, fetal hypoxia. Okay, fetal or maternal hyperthyroidism. Okay, fetal anemia, fetal cardiac abnormalities, rhythm abnormalities. Anything can give rise to fetal tachycardia. What is fetal bradycardia, Daru? Have a look at this CTG. What is the baseline heart rate? It's around 80 beats per minute and continuously 80. Initially, there was a little bit more than that, around 100, and it's dropped and is remaining at 80. So this is fetal bradycardia. Heart rate is about 80. What are the causes for fetal bradycardia?
Fetus is sleeping?
Even the baby, this might happen in adults, right? When you are sleeping, like at the end of or at the middle of this class, your heart rate may be like 55, 50 like that. But babies, even the babies sleep in the room, the heart rate will not drop below 110. That's not applicable for a fetus. Fetal hypoxia is one of the reasons for fetal bradycardia is fetal hypoxia. Again, fetal hypothyroidism. Hypothyroidism. And other thing is fetal cardiac problems. Fetal cardiac rhythm problem, and the rhythm abnormalities are there. Sometimes you can get fetal bradycardia. So you can now understand whether it's tachycardic or bradycardic. First thing you have to think is fetal infections or infections. Sorry, the hypoxia. Sorry, hypoxia and infection and all these things for a tachycardia. Okay, so when you take a ECGs or a CTG, first see what are the general information. Are there information given for you all to identify the patient? Okay, patient's general information. Then we'll see what is the baseline heart rate. Okay, and see whether it's tachycardic or bradycardic. If it is tachycardic, what can be the reason? If it is bradycardic, what can be the reason? Okay, so far we have discussed about this general information. Fetal baseline heart rate you should be able to mention. Baseline heart rate. Okay, the next feature is called baseline variability. Baseline heart rate, then baseline variability. Baseline variability. What is baseline variability? So baby's heart is not a static line. It fluctuates within certain limit. It fluctuates. If you look at the CTG, Darwo, you can appreciate there is no static line like this, but it's going little bit ups and downs. In each and every beat, there is a variation. This is called fetal baseline variability. This is one of the main important key feature of fetal well-being. In other words, if you see a good baseline variability, that means highly unlikely that baby is hypoxic. Okay, so see, if you look at the CTG, look at the CTG, you can see the fetal heart rate is not a static line, it's going slightly up and down, ups and downs, right? So this is called baseline variability. Then see whether you have this kind of a baseline variability or whether the baseline variability is reduced. If you look at the CTG, look at the CTG on the left-hand side, this CTG. Okay, what is the baseline heart rate, Daru? It's very easy to tell in this case. It's about 130, 135, like that, isn't it? That range. See, any fluctuations are there? No, hardly any fluctuation. It's just like a line, like single line. So this is called reduced baseline variability. If you look at the right-hand side, the picture on the right-hand side, that's what CTG actually taken today, right? This CTG, see, again, reduced baseline variability. Variability, beat to beat variation is not there, it's a static line, but there are some shallow decelerations and all this, right? So this is again a case of reduced baseline variability. Okay, so actually baseline variability you should not measure, nor need to measure it. It should be between 5 to 25 beats, 5 to 25, right? 5 to 25 is the normal baseline variability. Like this, but you don't have to measure it. If you go through 100 CTGs, then you know what is the normal baseline variability like. This is normal. This is normal. You can see here, if you start from, this is normal baseline variability. This bit is normal variability. This bit is normal variability. And this part is normal variability. And this part is normal variability. You can see. Okay. And then see whether the baseline variability is reduced, like the picture I shown you before. If the baseline variability is reduced, what may be the reason? Again, hypoxia. Hypoxia is one of the reasons for reduced baseline variability. Infections also can cause that, but main reason is hypoxia. And I haven't mentioned here, you may have CTGs like this. You will have a good baseline variability like this. And after sometimes this flat line, reduced baseline variability. And afterwards it again activates, something like this. What is this pattern for? This is completely normal. That means you have good baseline variability followed by a flat line, reduced variability. Again, good variability. This is called cycling pattern. Cycling pattern is 100% normal. What do you mean by cycling pattern is this type, have a look, everybody. This good baseline variability time, this time baby is active. And this time baby is sleeping. And this time baby again awake. And there again, now there are only two things the babies can do. What are those two things? But ඇතුළේ ඉන්න ගමනක් ගන්න පුළුවන් දේවල් කෙල්ල බලන්න යන්න පොඩි වලක් බහින්න යන්න පුළුවන්ද බෑ කොල්ලොත් ඒ කියලා පොඩි නිකන් chat එකක් දාලා එප්පට සුවම් මල්ලි කියලා අහන්න පුළුවන්ද බෑ right so what they can do actually when they are inside ඔය අම්ඩ වගේ පොරක් හිටියොත් නම් අල්ලපු ගෙදර කොල්ල දිහා කෙල්ල දිහා හැමත් බලන තියෙනවා but otherwise usually what does this baby can do when they are inside? They are awake and they do some movements here and there, right? And they go to sleep. And after some time, they get up and do some movements. And mother also now happy, my baby is moving. Magi daru sampata dangalana, something like that, right? Mother is happy, and after that, he will go into sleep. These are the only two things they can do when they are inside. Okay, that will be shown in the CTG This is the time where the baby is active, and this is the time where the baby is sleeping. This is called cycling pattern. If you see cycling pattern, that is not abnormal, that is 100% normal. That is 100% normal thing. But if you see continuously this variability is less and less and less, there is only flat line, is not showing any fluctuation, that is hypoxia, that is abnormal. Okay, so this is reduced baseline variability. Just for the interest, I'll show you this picture. See what is the difference between that picture and this picture. Here, actually, you can't identify any baseline because it's going this way and that way, this way and that way. Right? So there is no stable line like that. Baby's heart rate fluctuates very fast at a wider range. This is increased baseline variability, or else this is also called saltatory pattern. Saltatory pattern. I don't think that they will show these things in the Excel because this little beyond your levels, right? Just for the interest, right? This is a CTG of increased baseline variability. Increased baseline variability. Like this. This is also abnormal. If you see saltatory pattern, this is also abnormal. You need urgent delivery. Okay. So this is not common, Daru. Even in my life, I have seen only once or twice, right? But still, from 2010, I think I'm doing obs and gynae, right? Still, I have seen only 1 or 2 CTG traces like this. Right? This is not common, but this one is day-to-day practice. You will see this one, reduce baseline variability. Okay, so when you see a CTG, first talk about the general information, then talk about what is the baseline heart rate. Baseline heart rate is about 130 or 135. And see what is the baseline variability. This baby is having a good baseline variability. Compared to that, this fetus is having reduced baseline variability. This is abnormal. This shows hypoxia. Both CTG is the same, almost the same, right? Then, first thing, the general information. Second thing, the fetal heart rate. See whether it's bradycardic like this or tachycardic. Bradycardia, you should know the differential diagnosis, and the tachycardia, you should know the differential diagnosis. Next feature is baseline variability. See whether it's reduced or increased. Increased ones are not that common, but reduced ones are common. Okay. So are you all clear up to this point? Yes. Then next feature that you have to talk about, when you interpret CTG is accelerations. Whether you can see accelerations. Accelerations. Okay, like this. You have the baseline heart rate and baseline variable like this, and sometimes goes up and come back to the baseline. Like this. In this CTG, can you all identify any of those? Yes, they are there enough. See here, there's 1, 2, 3, 4. Right? From the baseline, if the heart rate goes up more than 15 beats or more, and lasts more than 15 seconds, that is an acceleration. From the baseline, it should goes up 15 beats or more. That means if the baseline heart rate is 130, to be an acceleration, at least it should goes it should goes 130 is the baseline. It should goes at least 145 or above, right? And it should last 15 seconds or more. If the pattern fulfills those criteria, you can say those are accelerations. Accelerations. If you happen to see these accelerations, right, if you happen to see this acceleration, that shows the baby is very active baby. When the baby is moving, doing some movements, you get the fetal heart rate goes up. We also the same, no? So when you are relaxing and on the exam, then pass and then chill again, bro, your heart rate also no much of fluctuation. You just baseline again. Oh, mean nothing. Heart rate but acceleration. Huh? So this is called acceleration. Now, when you look at this CTG, the baseline is there and you can see the accelerations. So this is a very good active CTG, very good reactive CTG. If you see 2 or more accelerations within 20 minutes period, that is called a reactive CTG. That means normal CTG, you don't have to worry. You don't have to worry. Okay. So general information, baseline heart rate, baseline heart rate, whether it's tachycardic or bradycardic, baseline variability, and the next feature is acceleration. Okay. What are decelerations? Same way like acceleration, the mirror image of acceleration is called deceleration. That means from the baseline, if the heart rate drops 15 beats or more, and if it lasts 15 seconds or more, that is called a deceleration. Then your heart rate goes down. Something like this. You get decelerations. If the baseline drops 15 beats or more and lasts more than 15 seconds, that means it's a deceleration. Okay, it's a deceleration. So, in this picture, have you noticed any decelerations here? No. It's a very reactive CTG, normal CTG. You can see the normal baseline heart rate and good baseline variability. There are multiple accelerations. So this is a very reactive CTG, nothing to be worried of. If I look at this one, I'll come to this one later also, right? Just see, what is the baseline heart rate? This is the baseline heart rate. It's about 130 beats per minute, roughly. Is the baseline variability is good? Yes, variability is good. And here, the baseline heart rate start dropping. Is dropped and dropped and dropped to about 60 beats per minute. It's lasted few minutes and now it's slowly recovering and went back to the original position. So this is a deceleration. It went down, it dropped more than 15 beats or more, and it lasts more than 15 seconds. 15 seconds, more than 15 seconds. So this is a deceleration. What's special about this deceleration though? If you look at this deceleration, I told you this one square is 1 minute. So if you calculate the duration of this deceleration, how much? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, roughly 12. It's 12 minutes of deceleration. That means her baby's heart rate dropped, but it failed to recover until 12 minutes. It's a significant prolonged deceleration. If the deceleration lasts more than 3 minutes, it's called prolonged deceleration. More than 3 minutes, if a deceleration lasts more than 3 minutes, it's called prolonged deceleration, a special kind of deceleration. If you see prolonged deceleration and if the baby is not recovering, you must deliver the baby as soon as possible. Usually category 1 cesarean section. Category 1 cesarean section. Okay. So far, what are the things we have discussed? General information, baseline heart rate, whether it's tachycardic or bradycardic, baseline variable, whether it's good, reduced, or increased, and accelerations, Now we are discussing the deceleration. Now, so far, even though I mentioned that when you are interpreting a CTG, you are talking about the uterine activity. So far, we haven't discussed anything about uterine activity. But when we are going to talk about the decelerations, always deceleration should be dealt with or will be in relationship to the uterine activity. You can see the uterine activity lower down. These are uterine contractions. So I'll come to that point now. Okay, when you come to decelerations, Darwani, this is a normal CTG. Here also you can see one uterine activity, that's one contraction here. So hardly any contractions. Probably this patient was not in labor. If the patient was in labor, you would expect more contractions than this, but this one just one contraction. Okay, hardly any contractions here. Now you can see, you can appreciate some other points like arrows, black arrows. 1, 2, 3, 4, 5, 6, like that. There are arrows. What are those arrows? Have you all,
When the mother feels the fetal movement, she presses the button.
Exactly. When you are doing this CTG, you paste this the electrodes on the patient's tummy and you give one gadget to the patient. Whenever she feels a movement, she has to press that button. So see how many times she has pressed? Lot of time, number of times. That means when you look at the CTG also, it's awesome CTG. There's no doubt, no suspicion at all, right? Rate is normal, variability is normal, accelerations are there, and then you can see mother also feels the baby is moving very well. So that means that reassures that she got a lot of fetal movements during this time. And you can see whenever she get the baby is moving movements, you can get some accelerations there. Okay, so that is a normal CTG. So these black arrows shows number of fetal movements where the mother felt. Now, the general things we have discussed. Now we'll be moving on to decelerations. Now, I told you, when you're going to talk about decelerations, decelerations always will be taught with the uterine activity. Uterine activity. Okay. Suppose these are the uterine activity, uterine contractions. Now, today, with nowadays practice, nowadays evidence, the way we are interpreting CTG is different. But this is the conventional way of teaching CTGs, right? I think in your exam, they will not go into this physiological explanation of CTGs, but they will be following the routine, the formal pattern of CTG interpretation. Okay. This is the baby's heart. If the baby's heart rate drops with the contractions and recovers when the contraction disappears, drop with the contraction but disappears when the contraction disappears. It's like the mirror image of the contraction. It's called early decelerations or type 1 decelerations or early decelerations. If you see this picture, Dargo, on the screen, right? You can see what is the baseline heart rate. What is the baseline heart rate? Roughly 130, 125, isn't it? Somewhere there. So baseline heart rate is normal. Is the baseline variability is good? Yes, good baseline variability. Can you see accelerations? Yeah, there are two accelerations also here. Accelerations on the, and same time you have decelerations also. See what type of decelerations. You got all these decelerations with the contraction. Now you can see this is the contraction. With the contraction, heart rate dropped. And when the contraction disappears, heart rate went back to original position. Here also the same. Here also the same. Here also the same. Here also the same. So this is called early deceleration. For you all to say early deceleration, Daru, baseline should drop or the deceleration should happen with the onset of contraction. And when the contraction disappears, the deceleration should recover completely. And in between decelerations, you should have good baseline variability. So if those two criteria are met, then you can say this is a early deceleration or type 1 deceleration. What is the reason for type 1 deceleration?
Cord compression.
No. Head compression during labor, not the cord, head. When the head is compressed, intracranial pressure goes up, baby. Intracranial pressure goes up. So you know the Cushing reflex. What is Cushing reflex? You all know what is Cushing reflex. When the intracranial pressure goes up, your heart rate drops. Right? That is called Cushing reflex. So this is a reflection of Cushing reflex. Okay. When the baby is trying to come out through the birth canal, the head gets squeezed, intracranial pressure goes up. As a compensation, as a reflex mechanism, the heart rate drops. So this is early deceleration, nothing to be worried of. It's normal, otherwise normal. What is next? See this deceleration. The heart rate has dropped, but after the contraction, it dropped. See here, this is the contraction. Can you see? At the peak of the contraction, still heart rate is normal. Then when the contractions start dropping or disappearing, the heart rate drops. Okay, these are late decelerations. Late decelerations, until proven otherwise, indicates fetal hypoxia, fetal distress. Okay, if you see these are late decelerations, you have to expedite the delivery. Expedite the delivery. What are variable decelerations, Darwini? Variable. Variable means it's like typical like women, right? Highly variable. So you can't predict them. When are they coming? They might appear before contraction. They might appear with the contraction, or they might appear after the contraction. And the amount they drop also varies. Sometimes it may drop to 100, sometimes maybe drop to 90, maybe 105, like that. So it's highly variable. This is called variable deceleration. If you see variable deceleration, that indicates what? Cord compression. Cord compression. So you have to be alert and you have to take some precautions to minimize cord compression, like you turn the patient in lateral position, hydrate the mother, and see whether this is improving. But if you see late deceleration, you have to really expedite the delivery. But variable deceleration, you can wait for some time and wait and see how it progresses. So there are three types of decelerations. Early means it's nothing to be worried of. With the contraction, it drops and come back, drops and come back. In between, variability is normal. Late means the deceleration comes after contractions until proven otherwise is pathological. Variable means you can't predict when these deceleration appearing, you can't predict. Maybe before, maybe with, or maybe after contractions. Okay, it indicates cord compression. And also, this is prolonged deceleration. If it is lasting more than 3 minutes, that's called prolonged deceleration. Okay, Darwini, right? And one more thing I want to tell you all, because that might appear on your exam. CTG is like this, right? How many contractions do you expect for the mother to have? Or how frequently you expect contractions to appear? Within 10 minutes, 2 to 5 contractions in 10 minutes. Maximum you can get, suppose this 10 minutes period, right? Maximum you can get 5 contractions, 2, 3, 4, 5. That's all you can get. Okay? If you get more contractions, more than 5, within 10 minutes period, something like this. What can happen to the baby? You know, when you have 3 contractions per 10 minutes, you have a contraction time and relaxation time also. And you have contraction time, relaxation time. During relaxation time, patient can breathe. Baby can breathe and get some oxygen. During contraction, baby cannot get oxygen, hypoxia. But when you have a lot of contraction without intervening relaxation, what happens? It's like that if you hold somebody's head and push it into a river where the water is there, right? Then you can't breathe. As long as the head and the face is inside, you can't breathe. When you take it out, you can breathe. It's like relaxation. When you put it back, you can't breathe. When you take it out, you can breathe. If somebody is keeping the head throughout within the water level, right? Like this, then basically you can't breathe. You are hypoxic. So same thing happened to the baby also. When you get a lot of contractions, without a minimal relaxation, then what happens? Baby can't get oxygen. Baby will be hypoxic. So initially, the baby is not IUGR or otherwise normal baby can withstand this for some time. So if the CTG is normal, if you get more than 5 contractions, that is called tachysystoly. Tachysystoly. Tachy means like tachycardia, right? Tachy means more number, right? Tachysystoly means more contractions. However, baby is still maintaining the heart rate and the patterns. Still the CTG is normal. After some time, what happens? Baby can withstand, right? Baby can withstand. It's like the people, like in Sri Lanka, right? The government was so corrupted and they did whatever the thing they want without neglecting people. The people tolerated and ultimately they blast like Aragale, right? Same thing happened to the baby, right? Baby will tolerate. If the contractions keep on going, what happens is baby will start giving up, right? So then afterwards, baby will show CTG decelerations and decelerations. If you are not stopping this thing, heart will stop. Set the boat. Right? So if there are CTG abnormalities also with tachysystoly, that is what is called hyperstimulation. 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 Okay, right? So you should understand what is the difference between tachysystoly and hyperstimulation. Tachysystoly means more than 5 contractions within 10 minutes period. However, baby CTG is still normal. If the CTG when the CTG starts showing abnormal features, decelerations, when the contraction more than 5, that is called hyperstimulation. Obviously, if you're not going to correct tachysystoly, next result would be hyperstimulation. If you're not going to stop hyperstimulation, next step is baby will die and the mother can get uterine rupture. Okay. Vilangida, understood? എപ്പടി സുഖം? നല്ല സുഖം? Okay, right. So today, with this short video, I discussed with you all regarding CTG. Right? So if you know this much for CTG, that's more than enough for your OSCE and even for your internship. Right? So see, when you take CTG, first thing is, see whether if you see this CTG, right? No one has mentioned about the patient name, age, BHT number, at what date, which time it was taken, nothing there. So this is a useless CTG because after some time we don't know whose CTG is this. If they have taken 3 CTGs in labor room, we don't know whose CTG is this. It's useless one now. So first thing is the general information. Next thing is the baseline heart rate. See whether tachycardic or bradycardic. Baseline variability. See whether it is reduced like this or increased like this alternatory pattern. Okay. And the next, accelerations, a good sign of fetal well-being, accelerations. The next would be decelerations, and decelerations can be early decelerations like this, late decelerations like this, or variable decelerations or prolonged decelerations like this. And also you should know what is hyperstimulation and what is tachysystole. Okay, clear? Have you got some idea, Daruni? Right? All right. So please go through this thing again, right? And then we'll meet up you all tomorrow, right, with the practical session. So don't miss this chance because I don't think that I will have another time to do these lectures again, the practicals again, right? So if you have a time, please come and join. And if you want to inform your colleagues also, friends, just inform them, all right? And try to participate and get the maximum out of it. And I think at the end of the day, you'll be really benefited with this exercise, right? Before your exam. Okay, any questions regarding CTGs? Have you got some idea regarding CTG? Okay.
Sir,
Yes.
how long should we wait if the patient, if the baby has late deceleration? So how long can we wait until we consider the C-section?
Yes, it depends, Daru, right? When you have CTG abnormal, not the early decelerations, talk about the late or the variable decelerations. Okay, when you have CTG abnormality, first thing what you have to do, you have to do a vaginal examination. See at what stage of labor she is in. Whether she is still in first stage of labor or whether she is now in second stage of labor. If you see late deceleration, the second stage of labor, that means also is fully dilated. If possible, go for a instrumental delivery and take the baby out. If the baby's head is still high, okay, if the baby's head is still high, CTG shows late decelerations. What you can do? If the syntocinon is going on, you stop syntocinon. Okay, turn the patient into lateral position, give some oxygen, hydrate the mother, and see whether she's improving. If the deceleration is still continuing while doing your conservative things, and even the patient is in the second stage of labor, head is very high, then go for a cesarean section and take the baby out. Okay. If the patient is in the first stage of labor, say OSCE is 6 centimeters, 7 centimeters, late decelerations on CTG. Again, you do these conservative things, right? Like stop syntocinon. Why you want to stop syntocinon? First of all, tell me. You want to reduce or stop the number of contractions because baby is now showing some features of hypoxia. If you give more contractions, baby will be more hypoxic. So stop syntocinon immediately. Then the contractions will disappear or the strength of the contraction will be reduced. So likewise, you can reduce the strength of the contraction. So likewise, you stop contractions by stopping syntocinon. If the patient is dehydrated, hydrate the mother and see whether your CTG is improving. If still your CTG is abnormal, like late deceleration, then you have to go for a cesarean section. I can't give you an exact time period that you can wait this long, Daru, but definitely if it is prolonged deceleration, of course, if the CTG is not recovering after 3 minutes, if the deceleration is going more than 3 minutes, you know it's a late deceleration. By 4 minutes, if it is not recovering, you immediately take this patient to the theater. By roughly 10-12 minutes, you have to deliver the baby actually, if it is not recovering. If it is fully dilated, go for instrumental delivery. If not, go for emergency category 1 cesarean section. Okay. Have I answered your question, Daru?
Yes, sir. Thank you.
Any other questions regarding CTG? No?
Sir, one more question. Regarding the saltatory variability, what is the management for that since it's abnormal?
Immediate delivery. If it is not recovering, because this can be something transient, like 5 minutes, 10 minutes, right? If it is 5 minutes like that, like you can, afterward, if the CTG is normal, then you can reassure, and with the close observation, you can continue the delivery. But if it is persisting, definitely more than 20 minutes, you have to go for again category 1 cesarean section. Immediate.
Okay, thank you, sir.
All right, okay. Any more questions, Tarwani? No? Right. Okay, good. Right. So this class actually will be helpful for your future career also as obs and gynae HO. So you will have to follow these things, right? So actually nowadays teaching regarding CTG is slightly different from this. I'll just tell you all for your interest, but if you can't remember it, just ignore it. We don't actually now go by type 1, type 2, type 3 deceleration. So early deceleration, late decelerations. Instead, we see when you see a when you see this deceleration, see whether it's a narrow complex deceleration or a broad complex deceleration. Narrow complex or broad complex, simply, right? Narrow complex, you don't have to worry of. It's a baroreceptor reflex. Whereas broad complexity like this, say, to drop, it takes a lot of time. And to recover also, it takes a lot of time. Kind of a broader one. This is hypoxia. This is called broad complex decelerations, right? That's a chemoreceptor reflex. That's a pathological one. Okay. And there are other variations also. I'm not going to make you all confused about this concept. For at your level, if you know what is early, what is late, what is variable, what is prolonged, what is tachysystolic, what is hyperstimulation, that is enough for your exam and other purposes. Okay, right? Clear? Okay, right. So we'll stop this class now, all right? And we'll meet up tomorrow, right? Have a nice day.
Thank you, sir. Thank you,
You're
sir.
welcome.
Thank you, sir.